Ankara, Turkey between the years 1992 to 2000. He was the Dean of the Medical School for 9 years and a member of the Turkish Higher Education Council for 4 years. For the past 20 years, he has been involved in many programs in Turkey and in the Middle East region, especially on immigrant child health matters. He has been awarded many honorary fellowship titles by various societies across the world for his tireless work and contributions to child health. Without further ado, to the professor who needs no introduction, to Professor Hasanoglu, the time and screen is yours.
Dear colleagues, I am Professor Enver Hasanoglu, President of IPA, President of International Pediatric Association. IPA is trying to reach about 2.5 billion of children with 147 national pediatric societies by 1,200,000 pediatricians to improve their health and well-being. IPA's mission is every child, everywhere, every age, and conducting meetings and webinars to reach the pediatrician to transfer to them new knowledge and information. Today's webinar entitled Kangaroo Mother Care. Dear colleagues, over the last decade, significant improvement has been made in infant health and survival, as well as in reducing infant death, particularly in regions with highest rate of neonatal death. As estimated, 15 million of infants are born prematurely each year worldwide. Half of babies delivered at 32 weeks or below 32 weeks die in low-income setting due to fundamental care lacking. As incubator shortage and longer hospital stays were hurting and killing previously stable premature newborns. To address this issue, Dr. Ray in Colombia in 1978 initiated an early discharge program in which infants were placed in skin-to-skin contact on chest of their mothers. It called kangaroo positions. Kangaroo Mother Care is reduced about 36 to 50% of mortality at discharge. All pediatric societies support this activity, and there is also joint statement among International Pediatric Association, American Academic Pediatric, and FIGO. And Kangaroo Mother Care is recommended by WHO for regular care of babies weighing 2,000 grams or less. I am sure this webinar will be benefit of pediatricians, and this issue will discuss in details by our distinguished speakers. Thank you. Dear colleagues,
Thank you, Professor Hasanoglu, for your opening remarks. The next agenda of our webinar will be moderated by a very special and distinguished moderator. It is my great honor today to introduce our moderator for the session. Dr. William J. Keenan, MD, is a professor in the Division of Neonatal Perinatal Medicine at St. Louis University School of Medicine. Dr. Keenan is considered a pioneer in the field of neonatal resuscitation and serves as co-chair of Helping Babies Survive Planning Group. He has also served as the executive director of the International Pediatric Association from 2016 to 2019. Dr. Keenan has traveled to more than 14 countries to train health professionals in neonatal resuscitation and other life-saving interventions. To Dr. Keenan, the time and screen is yours.
Well, thank you so much. And we are blessed today to have three very skilled pediatricians who are connected to the everyday problems facing each pediatrician both in leadership and in application. And our first speaker will be Dr. Singhal, who is, really quite prolific and helping us improve the care of children all over the world. So I really want to, identify my friendship with each of these because it complements me so much. But Dr. Nalini is very, very special in international and North American pediatrics. So Nalini, please proceed.
Good day and good evening, everybody. And it's an honor to share some of my ideas, which our president already set the tone for. I think the time now is right. There are a lot of things that are in neonatology, things like antenatal steroids that took over 25 years to really implement. And I think the 25 years for KMC are up, and it's time to actually implement it at scale. I'm going to talk a little bit about the definition and then a little bit about what we can do to go forward for implementation. The WHO vision is that every preterm or low birth weight infant in low and high income settings, that is very important, alike, will receive KMC immediately after birth, along with other life-saving interventions to improve their survival, growth, health, and development. So even though it started off because we didn't have incubators, that's no longer true. We have to recognize all the benefits so that this is not if we're short of incubators or short of money, or it's the right thing to do that has to happen for every baby in every setting in the world. The vision and mission of WHO is that the mother and baby are never separated. They receive combined care as a unit, and that's going to require transformation of care with our obstetric colleagues, with our midwives, to make sure that the mother and baby receive care as a unit. Every preterm newborn is alike in all settings, so it doesn't matter if it's high or low income settings. It should be started after birth, and we know that it will improve survival. But not only that, it also improves the mental health of the mother and decreases some of the mental health issues like postpartum depression. So what is it? What is the definition? And we've had a lot of discussion about this, and Dr. Bahl is online, who knows that it was difficult to actually come up with a definition. Nevertheless, this is the best we could do, and this is what we're going to follow, as it's the care of preterm infants, gestational age less than 37 weeks, or low birth weight infants in skin-to-skin contact with the mother. Key features will include skin-to-skin contact and the mother and baby early, initiated after birth, continuous and prolonged, but it can be 8 to 24 hours. So it doesn't always have to be 24 hours. And support for exclusive breastfeeding or breast milk feeding. So as you can see that people will feel that it's not comprehensive. It should be more comprehensive, and they can always add on what they think should be added on, like discharge at home. However, this is the definition that we're going to use for now. So we started, this picture that I show you here is of Chicago World Fair, where we started with putting babies in the 30s in the boxes. And right now, we have fancier boxes. However, we need to transform the neonatal care from the machines providing the care for our small and sick babies to the family providing the care and us helping the families provide the care. Now, if you go to implementation, we know that medical science times educational efficiency times local implementation leads to survival. So the utopic would be we have 100% of the science, 100% of the efficiency, and then 100% of local implementation, which would be great. But we never reach that. Where are we now with KMC? Well, we've got more than 80% of the science. We've developed some education programs. I will show you a brief outline of it. So we've got some educational efficiency, but what we're lacking is the local implementation at scale. And that's where we can all help with providing support to these babies. We know the science, as I said. It decreases hospital mortality, it decreases sepsis, decreases hypothermia, and improves discharge breastfeeding. There's improved weight gain, increased length, increased head circumference, length of stay is decreased. And in the studies till now, they found no psychomotor differences, but there are some more coming out now that find that there are differences and improvements in survival. This meta-analysis, as you can see, is an old one, which is being repeated. So we know that these things, we know it works. So what can we do with the education? Well, the IPA has been helpful in, and they will be posting the link for a Kangaroo Mother Care learning package that actually integrates quality improvement with KMC. Some of you are very familiar with these colors. They're the Helping Babies Breathe colors originally, and they take care of essential newborn care. And the program is going to address preparation for Kangaroo Mother Care, healthcare learning, family learning, and the goals. The key part here is it's going to be more about how healthcare workers can help families learn, and not just education of healthcare workers, which is what we've focused on to date, and the integration of quality improvement, which we think will really make things much better and stronger. And we have some experience that it actually does what we would like it to do. And the link will be there to download the programs. So what are the barriers? Before I leave the programs, there are other programs that Columbia has had, that the KMC Foundation of India has, CRO has. So it's not that we have to use one program, but this is a simplified one for the families. So the barriers to change have been our government, our institutions, but us ourselves have been big barriers also. And our patients culturally and our colleagues. So how can we address the barriers? And we're hoping that doing it in a quality improvement structured manner, it will help decrease the barriers and help us find local solutions. The challenges for achieving scale up have been that large part of KMC community believes only 24 hours is good enough. Well, that's not true. We found that even 8 hours is very helpful. A large portion of healthcare providers still believes that high-tech solutions, incubators, warmers, and sterilized ICUs are better. And we have to advocate that that's not the right approach. And the mother and ICU challenges the mindset, both of pediatricians and neonatologists, but also the infrastructure and our obstetric colleagues and midwives. And midwives might be the best farther ahead in believing that this needs to happen. So then you ask yourself, well, I live in one environment, and should I be, how do I adapt it? Well, you can look at tertiary level centers, and but it stays standard, whether it's a referral tertiary center, second level, first level, or a community. As Dr. Vani keeps reminding us, it's the baby's size and baby's gestation, and it can be provided in any environment. But no matter where we start, we've still got to pay attention to how we're going to provide KMC, whether it's in an NICU, where you want to provide CPAP, well, that can definitely be provided with KMC. Whether it's a ventilated baby, which the Swedish people have shown us is not difficult to do, whether it's in the community. So what we have to do is we've got to think that no matter where we are and whatever level we're functioning in, we can all do it, unless you're resuscitating the baby or your own cutoffs in your own organizations are different in your country. Then you determine when you're going to provide it, not if you're going to provide it. Oh, doesn't want to advance. So I'd like to leave you with the fact that the role of the physicians should be to support and help the families and the care providers, education, helping educate healthcare providers and families, and supporting the healthcare team, and advocacy, because unless we advocate for our babies, we won't be able to do it. So what can we do as next steps? As professional associations, we can accept, advocate, and help implement the paradigm shift and help in transformation of care. They can incorporate KMC into clinical service and pre-service education. We can make sure that all our funding agencies that are funding newborn programs look at KMC as an integral part of MCH activities, and we can integrate quality improvement into all neonatal care, but we can start with KMC to begin with. Thank you very much, and I'll stop sharing my screen and pass it back to the IPA office.
Well, thank you, Nalini, and that was terrific. As I mentioned, we've got these three leaders of pediatrics that we're so grateful for. And, you know, as Nalini said, it's the right thing to do. How can we not proceed? And she also made the point that it saves babies, helps babies, and helps their families. Again, how can we not proceed in this direction? So thank you, Nalini. Our next speaker is Dr. Vani, who is admired by me greatly, and I've come to know her nicely over the last year. She's widely respected around the world, and she has been working with the KMC Foundation of India, and she's got this important experience to share with us. So grateful for you, Dr. Vani. And, you know, there's the introduction here that is numerous about your accomplishments, but we want to spare this time to hear from you. So thank you, Dr. Vani. Please proceed.
Thank you very much. Can I ask them to share my slides, please? Thank you. First of all, I bring greetings from India. Next slide. And today's topic is KMC's success in India and what we have learned about acceptance implications. I thank the organizers for giving me this opportunity to share some of our experiences and learnings from our experiences over past almost 3 decades. Thank you. Next. Now, in this presentation, I'll take up 3 aspects. First of all, why India or countries like us need to promote Kangaroo Mother Care, which has already been told. What are our major barriers? Then I will give some of the innovative approaches which have been developed by KMC Foundation India with their own limited resources, but they give some indications that they may address many of these barriers if taken to scale, and then share a few important learnings from our experiences. Because of the time constraint, I will just give the headlines and we will take over here. Next. As all of you already know, India has got the maximum load of neonatal healthcare burden. And more important is, we have got the highest number of births, highest deaths, incidence of preterm and low birth weight babies, and wide disparities in the urban-rural setup, rich-poor setup, male-female and gender context, and so many other factors. We have some regions which match with any other international country in terms of mortality figures, and at the same time, some of them are doing not so good. So with this background, next, we are making some lot of progress, and we have succeeded in reducing our NMR from almost to 50% from what was earlier, and still some progress is there. And many important programs have been included, and institutional delivery rate has gone up. But with this, again, we appreciate, next slide, please, that in countries like ours, where neonatal mortality is very high and the public health systems are not very strong, we need to promote simple interventions like promotion of breastfeeding, Kangaroo Mother Care, hand washing, and look into our local traditional practices and so on. So with this background, we appreciated the importance of Kangaroo Mother Care promotion in India, and we started it. Way back in 1993, we were the first one to introduce it in Ahmedabad. And from that, we took almost 20 years. That is in 2013, the program was introduced in the government setup. Means it was taken up as a national policy. We had so many networks working, but then we organized one international conference in Ahmedabad in 2012, and probably that became the first major milestone for introducing KMC in the national programs. Next. And we have got now several, next please. And now we have some possible indicators that KMC is likely to succeed in India. It has been introduced in national policy, national guidelines have been laid out. There is a rollout plan by the government, national collaborative centers, centers of excellence, technical advisory committee, and integration with family participatory care, and so many other developments have come. And recently, budget allocated for forming mother and newborn care units, both in the stabilized units as well as in the ICUs. Thankfully, many international NGOs are also supporting us, and we are getting partnership from many professional organizations also. And I must say, the contribution of the local KMC champions, which includes our foundation also, is very significant, at least at this stage, in stepping up Kangaroo Mother Care in India. Next. And currently, we have set the targets of achieving 90% coverage of KMC by 2030. And we have established some of the special newborn care units in the districts to cater for the newborn care. And KMC coverage data is available only from these centers. And that also says that out of the 11 lakhs or more children, newborns who have been admitted in this, about 25% coverage of KMC is there of total admissions. And there are incidents of 51% or more of low birth weights in SNCUs. Amongst them, how much KMC is practiced, still the data is being compiled. And data from public sector and the medical college hospitals or other hospitals and private hospitals is not available. And unless a good data, quality data is available, it is very difficult to judge about the success of the program. Next. And we have faced many major challenges which have already been said. The first and foremost thing, according to me, is the non-conviction by the senior consultants of pediatrics, neonatology, obstetrics, and people, and to some extent, even apathy of these senior consultants in promoting Kangaroo Mother Care. In many places, there are local champions are available, shortage of well-trained staff, motivated infrastructure, and so many other well-known barriers are there. And luckily, we have got now so many positive inputs from the government. And if we fail now, we really cannot achieve much. Next. And here I am trying to introduce our foundation and some of their activities, only from the angle of saying that few activities which we have taken seems to contribute to upscaling of Kangaroo Mother Care. And similar activities can be taken up by other agencies who are much more. We are working with very restricted resources, but others can take up some of the messages from here and upscale these activities. In fact, subsequent some of the research programs also have endorsed that whatever activities we have been doing, we have been on the right path. Our main thing is to support all the government programs and take up also some of the independent innovative activities which are aimed towards advocacy and demand generation in public and policymakers, improve the training capacity and motivation of the service providers, which includes master trainers, service providers, community-based health workers, take up some of the relevant research studies which are applicable for our context, establish a KMC accreditation system for the newborn years, and make sure of the quality improvement. Next. With this background, though we started KMC in India from 1993-94 onwards, and several other attempts were going on, only in 2015, after the national policy was taken up, we thought of forming a dedicated foundation. And our mission is mother's chest is the best place for the newborn. Mother's milk is the best food for the newborn. Zero separation of mother and her baby. And KMC should be a part of routine care of all the newborns. We do appreciate that it has special benefits for low birth weight, including preterm babies. But it is not restricted only for them. Even the term babies, whatever few hours they have, skin-to-skin contact, including breastfeeding, that also gives them a lot of advantages. And another paradigm shift, which was suggested by Dr. Niels Bergman, incubators and warmers do have a place in our newborn care, but they should be used only when KMC is not possible. Each one can take audit in their own setup and decide for them. Next. So I'm just telling some of the innovative approaches as a quick show. Next. We are taking training programs, but they are just not one type. They are for the master trainers also, which for the facility-based KMC. Then we are also taking for the providers separately. We also have introduced home-based or community-based KMC training for the trainers of the CHWs, that is community health workers. And now we have even started realize the need for training the obstetricians, private practitioners, tertiary care providers, and even mother support groups. So we are expanding the scope of training, adapting to the need for the different groups. Next. And as you can see, almost all the states we have tried to cover, and there are many more things to do. Next. And many charts and job materials we have developed. Next. And they have been developed appropriate to individual languages also for some of the states like Andhra, Maharashtra, Gujarat, and others. And we are also developing some contextualized material. Next. And such charts to promote quality of Kangaroo Mother Care and support to the mother also developed. Next. And one important contribution is every year now from 2017, we are regularly organizing a national KMC conference with a specific theme. You can see the different themes which are very much needed and relevant to our context in India. that is improving quality and coverage of India, widening the horizons and so on. Next. And these conferences are conducted in different cities, thereby stimulating the different cities also for the KMC promotion, different states also. We have also invited different professional bodies every time by rotation and make them commit by issuing the joint statement for supporting KMC. Next. And as you see, we go beyond the scope of pediatricians and nurses, we involve many others. We have introduced oration so that people can listen to KMC champions and their activities and get lunch. Next. And we have organized some special workshops which we thought are very important for upscaling KMC in India. One is first KMC in resource-restricted regions, and our plea is to introduce that as a part of home-based newborn care. We do not want KMC as an isolated program. We want it to be integrated in essential newborn care program, but dedicated training programs are required because we have to develop full scale and full skills for the KMC. Quality improvement is very important, which has already been said. We want to introduce in transport, we want to introduce in the tertiary care units, and role of obstetricians also we recognize more, and so on. I can go on. Next. And a quarterly newsletter also gives all the messages, including the recent research activities as well as whatever actions are going on. Next. And KMC awareness program, demand generation program for the public and educational activities also conducted through several of important days, as you could see. We celebrate them, involve the public also, involve the mothers, involve the local social workers, and even organize KMC exhibitions. And all these programs are inaugurated by KMC children immediately. That impresses the public about the significance of Kangaroo Mother Care. Some of the interesting, important case studies are also mentioned. Next. And certificates and awards are given. We are promoting recent research papers. Next. I'm just going through this just to show. From these, what we have learned, that newborn care, which is, I'm just supporting that it is not only for the mere survival and for good nurture and well thriving of the baby. And KMC, including promotion of breastfeeding, forms a sound foundation for early child development. I am mentioning this here because in many literature and workshops, I find only a cursory mention about KMC and breastfeeding promotion. Of course, breastfeeding is mentioned more, but Kangaroo Mother Care also has its own contribution, significant contribution in early child development. So that has to be mentioned. And in upscaling of the KMC is needed urgently, which everybody has realized now. Next. And only some of the earnings that don't trivialize or simplify KMC. Still people feel it is only a poor man's incubator. So that should go, and KMC is a comprehensive newborn care method, which Dr. Nalini also has mentioned. It is low cost, but needs high skills to get high impact. And funding is required, though it is much less, for building the capacity of the service providers and for creating infrastructure for which is suitable for the mothers also, as well as for the baby's care, and public awareness activities, and promote research which is relevant to our operational needs. And more professional organizations need to be involved in this. Next. And then regarding training, as I already mentioned, it is not to be a vertical program. It is a part of the basic newborn care. But still dedicated training is needed because through government programs, so many programs mention KMC, but the participants did not get the competence, confidence, or compliance for practicing KMC. They did not have the confidence to start KMC program. And that is why a detailed program was required, so that that will not only build up their competence, knowledge, but also motivate them to take this up program. And there are so many inputs required there. Mainly, I am highlighting counseling at multiple stages is required, not at one stage. So all these details we have taken up. Discharge policy have to be revised, and setting up of KMC facilities also has to be taken up in the training program itself. A separate training module is required for each state in their own language, which is adapted to their local context and culture. More frequent sessions are required for all categories of health workers. Just one time, one dose will not do. And hybrid self-learning courses with certification also have to be developed. We have all made some efforts in these. We can share our experiences. And it is time that pre-service education of nurses and medical students include KMC, not just the nomenclature, but even the practical aspects. Next. This is another important aspect. I feel urgent attention is required from developing countries like India. We need to strengthen home-based KMC through community health workers, and we have to modify our approaches. Just to give one example, we need not wait for the low birth weight or preterm babies to be identified and then to start KMC. We can just say all the newborns can be started with the skin-to-skin contact. Mature babies are going to leave it, and the needy babies are going to continue. And so many other details we can tell. Because of the time constraint, I'm not telling. We have developed a module also. We have had experience over the past 10, 15 years promoting it, very carefully studying this feasibility, acceptability, and the replicability of this program. And now we are ventured to plea with all the agencies to promote this in a big way. Next. And the transport of baby in kangaroo position is another simple, doable intervention at multiple levels. It needs to be introduced with proper guidelines and proper instructions. Next. And then National Health Monitor System has to be improved. Today, we just have one word KMC done, yes or no. But the definitions are not clear, nomenclatures are not clear. And one more important aspect I would like to say here, when we are defining kangaroo position, in each session, it should have been done not less than 60 or 90 minutes. And that should be an important criteria, along with, of course, total cumulative duration of kangaroo position in 24 hours. There are many other aspects I would like to take, and for that, the national consultation is required. And another important thing is, in Indian context, many mothers do not have a planned early discharge. They cannot wait in the hospital till they satisfy all the discharge criteria. They leave earlier. So in this random discharge group, the outcome is different, and they need a lot of support for the home-based KMC. The National Family Health Survey, which is our national data system, in that Kangaroo Mother Care also should be now included along with the breastfeeding. And just as we have got 10 points for BFHI, now many countries have suggested 10 points for Kangaroo Mother Care, and we should suitably incorporate them in our points also and take it as an accreditation point in all the newborn care services. Next. Roles of other professionals. Here and just each professional has got their own significant role, including obstetricians and those from the preventive and social medicine and breastfeeding promotion network and so on. And just illustrating one point, obstetricians have a lot of role to play, starting right from antenatal counseling, promoting early skin-to-skin contact for at least 1 to 2 hours, and early initiation of breastfeeding, even in cesarean cases, and then art and early expression of breastfeeding. Breast milk also has to be told properly. Zero separation concept also has to be bring, and expanding the scope of lactation counselors. In all these, the obstetric colleagues can play a lot of role. And one more in the context of India is, everywhere we do not have neonatologists or pediatricians to take up their role. Obstetricians also are the newborn care providers. So in that context also, their role has to be upscaled. Next. And there are so many other activities we can take up in the promotion of KMC in the community, which we are doing it, but still in the national media or national thing, we have to promote it in big way. Because of the time limit, as I said, I'm just quickly giving you a bird's eye view. Next. And all these we have tried, and especially in COVID period, right in the beginning itself, we they issued our plea for everybody that do not separate COVID mom from her infant, and all the details we had given. Next. So with all these things, I must say that KMC promotion requires in all the countries, but it requires suitable modifications, suitable expansion, suitable quality improvement, and all the details. But we should give a lot of importance to it. Once again, thank the organizers for giving me this vital opportunity to share some of our experiences. Thank you.
Well, thank you, Dr. Vani. This is Bill Keenan again. Just thank you for the skill and dedication that you shared with us, and your contribution of valuable communications and how we might proceed. So thank you very much. Our next speaker is Dr. Rajiv Bahl, who I also claim as a friend, as I have with each of the other speakers. And he is a key representative of pediatrics in all of the global settings. And he has a key central role as a pediatric leader in WHO. His abbreviated CV is on the screen, and in terms of his perception, his research, his contribution, his help for others, it's unparalleled. So welcome, Dr. Bahl. Thank you.
Yeah, thank you. Now I am unmuted. Thank you very much, Dr. Keenan, and certainly greatly value your friendship and the work that you have done. And thanks very much for those kind words. What I'm going to do, my work has been made quite easy by Dr. Nalini Singhal and Dr. Shashi, both great leaders in this area of work. And I'm going to just tell you a little bit of a recent story of how we have used the recent advances in Kangaroo Mother Care at WHO to promote not only the research, but research to scale up in countries. And I have only 4 or 5 slides, but if I take too long, I should keep a watch on my on time. Can I go to the next slide, please? So this, click once more, please. Yes, and once more. So this is just a story of the past 7 or 8 years. We can stop and then we can do, yeah, you can click on all of them if you wish. Yeah, it's okay. I can just start the story. So we looked at in 2014 for what were the remaining research gaps for Kangaroo Mother Care, and identified 3 research priorities. And those are listed below. One was that why is it not scaled up? Why is it 10%, 5%, 20% or lower in most of the settings? And what can we learn from implementation research to scale up? The second question was, can KMC be initiated outside of the hospitals, in the community, at home? And the third question was, at that time, should it be done as currently recommended only for stable babies, or can it be initiated immediately after birth? And those were 3 questions we did support as WHO, 2 trials and 1 implementation research project. And these have all been published. The community KMC scale-up research, the KMC scale-up research was published in BMJ Global Health, and it was conducted in about 8 million population in India and Ethiopia, and showed that you could achieve 80% or higher coverage by overcoming some of the things that Dr. Shashi Vani and Dr. Nalini Singhal pointed out. Most important being the conviction of health workers and senior pediatricians and neonatologists that KMC is the standard of care. That was one biggie. The other big one was that the mothers are provided respectful care and are given the opportunity to be with their babies. So they have access to a bed, they have access to food, toilet, showers, and etc., so that they can actually provide kangaroo care. And the third issue was the actual identification of babies and making sure that all of them actually received KMC. The big ones were these. We did not find that mothers or cultural issues or families refusing to give KMC as a very important issue. In the community KMC or community initiated KMC study, babies were initiated on KMC if they were not done so in the hospitals or if they were born at home. This study was conducted in India, published in the Lancet in late 2019, and showed that community-initiated KMC reduced mortality by 30% compared to no KMC. The third trial, the third big research project, was the immediate KMC RCT, which was conducted in 5 countries in hospitals, where we tried to look at whether initiating KMC within 1 or 2 hours of birth was actually better than initiating KMC later. And the difference between those 2 strategies, both of which received KMC, one starting early, one starting after the baby was somewhat stable, there was a huge difference in mortality, 25% lower mortality with immediate KMC. This is a paper which was recently published last year in the New England Journal of Medicine. Many of you would have read these publications. But what is new is that WHO has now revised its guidelines on care of preterm and low birth weight babies. These guidelines have been approved. They will be published in the next 2 to 3 weeks. And the big changes from previous guidelines is that KMC is now recommended for all preterm and all low birth weight babies, not only for those below 2 kilos. It is now we have put a limit, a lower limit, that it's not enough to just have a few minutes of KMC a day or just initiate KMC, but it has to be prolonged in skin-to-skin contact, at least 8 hours a day, but going towards a maximum of possible 24 by 24 if possible. The third change is that it can be initiated in the community if it is not possible to initiate in the facility. And the fourth change is that it should be initiated as soon as possible after birth and not wait until the child is stable. So those guidelines will be available for you as WHO guidelines very soon. If you click once more. So now inclusion of the new guidelines and incorporating them within the small and sick newborn care, so that KMC is not seen as an individual program, as Dr. Nalini Singhal very nicely showed us, but also, and Dr. Shashi Vani, although her focus is KMC, we would like that all babies receive interventions when they are small or sick, including respiratory support, including management of infections and all other care, not only Kangaroo Mother Care, but how do you integrate KMC? And a few examples of what is being done. If you click next, please. So there is a stage which is a high-level WHO expert committee on maternal newborn child health, has set up a KMC working group to align all partners. IPA is a very important partner. So is PIGO. So is International Midwives ICM, Nursing Confederation, and others. But there are many, many partners. which have come together, and Dr. Nalini Singhal tried to pick some of the things from even those documents that are being prepared by this KMC working group. Next. Implementation research, particularly on immediate KMC. WHO is initiating implementation research on these mother newborn ICUs in 4 countries. Starting soon, we have received funding from Bill and Melinda Gates Foundation to conduct this implementation research so that we can learn more about its implementation. Next. Dissemination and policy dialogue. IPA, this webinar is a great way of doing that. But so is, there are several other agencies, and in particular, I would like to call out American Academy of Pediatrics, and they are taking leadership in making many country program, and they've already had a town hall in Nigeria. We are planning it in Brazil, in the US, as well as in India in the coming weeks. Next. And monitoring. We have an indicator now for routine monitoring of KMC coverage that will be soon published as well, which will be available for routine HMIS to include in every hospital. Next. Please. So this is the biggest transformation in newborn care, according to us, with regard to probably the previous 10 years, is this idea of really promoting mother newborn ICUs, which was started in Scandinavia, in Sweden, Karolinska, etc. Next. I will not go into details of how KMC can be implemented. You saw a similar figure in Dr. Singhal's presentation. This is slightly updated, but essentially it is that KMC can be incorporated at all levels of care, from community, first level, secondary care, as well as tertiary care. And it is very important to initiate KMC as soon as possible after birth, but also continue it until the baby is in the hospital. Next, please. I want to spend 2 minutes. Next slide, please. I want to spend a couple of minutes on the mother newborn ICU, which we think is really a revolutionary idea for neonatal intensive care. And as you can see, these pictures are from the immediate KMC study. On the left from India, right is Tanzania. So it is actually a level 2 newborn care unit with all the equipment and all the warmers, etc., and all the other equipment required, CPAP, whatever else. But the difference is that the mother is with the baby, and if the mother is not available, the surrogate is with the baby. Next slide, please. So I just want to say, if we want to achieve this zero separation, we need to think about the mothers and newborns to be in the same place for provision of care, right from the time of birth or whenever the mother is ready, and until then, a surrogate family member. But whether it is in the newborn care unit, whether it is in whatever step-down unit we call as KMC ward, or which small or sick baby ward or what, and also in the special places in the postnatal wards. Zero separation requires that we have a policy that permits mothers and surrogates to be with the babies in the NICU 24/7. It requires a very, very good obstetric neonatology collaboration where the care of the mother does not suffer. The mother is cared for at all times by the nurses, midwives, and the obstetrics team within the mother newborn care unit. And the facilities that are required for hand hygiene, toilet, shower, bed, food, dining area for the mother, so that she is not left to her own devices, but she actually gets the support that she needs to provide care. How does last slide, and I'll finish in a minute. Nalini already talked about the role of how IPA members or pediatricians can help. I think very importantly, you all can be the champions for KMC in your own hospitals and in your own communities, so that you promote KMC as the standard of care for preterm and low birth babies. You promote initiation of KMC as soon as possible after birth, along with other newborn care interventions, not alone, but as part of sick and small newborn care. Make sure that mothers are not forgotten. They are given respectful care where they think that they are valued. They are provided with physical facilities, but also with the respect that they deserve to be caring for their babies in the newborn care units. And please do consider thinking about your NICUs, that should we be having them from the 1800s, like the Chicago Fair with babies in boxes, or should we be actually converting them into mother newborn intensive care units to achieve zero separation? I'll stop there. I know we have not got much time for questions, but back to you, Bill.
Well, all I can say is, wow, 3 wonderful leaders sharing with us. I feel more informed, and I pride myself on trying to be informed. I feel energized, but I also feel challenged by what do I need to do to be helpful and to make a contribution. So I'm not sure I have any of those answers, but certainly grateful for the presentations. We have a little bit of time for question and answer, but we don't have very much time. One of my proposals is that you could forward your questions that might get reformatted now that you've heard the presentations to the IPA office, and then we will endeavor to respond to each question that gets asked. And the speakers have indicated their willingness to participate in that. So feel free to communicate, and we will try to make this a continuing conversation and support each other in the implementation and improvement in this really very critical piece of newborn health. So again, thanks for everything. So one question that we might take up for the panelists would be, there's been a number of questions about family involvement, how to interest them, how to help them, how to include the rest of the family besides the mother. So if maybe the 3 of you would take that on just very briefly, and we'll delve into some of the intricacies as a follow-up. So Rajiv, you want to give a little bit, and maybe
thank you very much. And I think from my perspective, I was trained and worked as a pediatrician for several years in the newborn care. You're one of the busiest ones in India, and in Delhi, at Kalavati Saran Children's Hospital. And somehow we always feel that we are the main providers of care and we need to involve the families. After doing all these research studies, my perspective is that families should provide the care for their babies and we should be the support. And I think I agree with Dr. Nalini Singhal in saying that very much. And I think key issues are, if we don't stand in the way, nature did not intend to separate the mothers from their babies. Actually, I feel that we as the doctors and pediatricians have stood in the way of nature by separating the mothers from their babies. And all I would say is, everybody on this call, if we can be the champions of making sure that the babies have access to their mothers to their guardian angels, then we would be doing a big service to newborn care. Over.
Nalini or Shashi, do you want to add to that?
I
Go
just
ahead,
want to
Nalini.
add one thing. I know the mother's the guardian angel, but the guardian angel needs a lot of help, as does the baby. And unless we reach out to the families, the fathers, the grandparents, the mother-in-laws, we are going to keep struggling. So I think we should be looking at a community of family care that provides the care to the baby. Mother is the key, she's the one that's given birth. But we have to have a place for the family, the fathers, and the extended family so that it's provided for as long as possible. Thanks.
Dr. Vani, I was wondering if you would respond to a different question a little bit, and that's many of the participants asked about the necessary investment that would be required. I mean, investment always means to me you put up something up front to get a return. But maybe you could talk. You addressed it a little bit, but maybe you have a few more words about investment.
A lot of communication with the community people, including mothers and their family members. And a lot of counseling is also required. And it should be in a dialogue fashion so that we say that whatever they are doing is okay, but some more things can be done. So that approach, that art and science of counseling, and that too at multiple stages, that itself is a great investment because that motivates the person, convinces the person, and then they cooperate with us. So that is one thing. And one end public and other end policymakers. So we have to talk to the policymakers and convince them to take this up because we have struggled with all these things for so many years. And that is why I'm just sharing this idea. And third thing is to bring out some of the successful stories or success stories to the public domain. They can know what can be achieved through the Kangaroo Mother Care. And that will also build up the confidence. And there are so many other things we can do.
Oh, thank you.
Then the policymakers and program managers, they will definitely help us out for planning, providing services, training, and other infrastructure and other things.
Well, let me just repeat that we want you to share your questions in a continuing fashion, and we can develop this conversation with this group, I think, over a continuing period of time. Arnetta, what should we do next?
Thank you very much, Doctor. It is now time for us to have a certificate presentation session to award our honorable speakers who have given their time today to share their valuable knowledge to us. So once again, we extend our warmest round of applause and appreciation to our honorable speakers and of course to our moderator as well, Dr. William Keenan, for the incredible and eye-opening discussion. As a token of our gratitude, we will now present certificates to our honorable speakers who have contributed greatly to our learning process today. To present the certificates, we now invite Professor Aman Pulungan, Dr. William Keenan, and Dr. Errol Alden to the screen. To our speakers, kindly turn your videos on and smile as we spotlight you alongside your certificate. We will now be taking the photo. 3, 2, 1. 3, 2, 1. 3, 2, 1. Thank you very much, Doctor. We will proceed to the second speaker. I will now be taking the photo once again. 3, 2, 1. 3, 2, 1. Thank you very much, Doctor. We will proceed to the final speaker of the day, Dr. Rajiv Bahl, for the photo session. 3, 2, 1. 3, 2, 1. Thank you very much, Doctor. And of course, no event is complete without a photo session. So we now invite once again our honorable guests, speakers, and moderators to turn your videos on to take the group photo. And to all the participants, please do turn your videos on as well, as we will be taking a photo with all our distinguished speakers, moderators, and guests. I'll be taking the photo once again. 3, 2, 1. 3, 2, 1. To all the speakers, to all the participants, there's still time if you'd like to turn your cameras on. 3, 2, 1. 3, 2, 1. 3, 2, 1. That concludes the photo session of today. Once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to our speakers, moderators, and participants for making the international webinar on Kangaroo Mother Care a great success. To all the participants, kindly fill in the feedback form as detailed on the slides, and that has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Furthermore, the International Pediatric Association also conducts routine webinars with a wide range of topics concerning child health. To keep yourself up to date, we urge you to follow IPA on our social media platforms as detailed on the slide. We also have several opportunities for you to participate in IPA webinar and activities. First, IPA will be having the IPA Congress next year in 2023. For more details, log on to www.ipa2023congress.org. IPA also provides opportunities for healthcare workers to enroll in the IPA Vaccine Trust course to become a certified vaccine champion. The course is open to all healthcare workers for free. Refer to the post and the IPA website for more information. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.
Thank you. Thank you.